Close your mic, we're just starting.
Yeah, just waiting people to log in. I'm in less than 1 minute we start. So, hi everybody, welcome to Congenital Heart Academy. We are very, very happy to have all of you with us today. It's going to be a fantastic fetal series as usual. And just a heads up, Dr. Norman Silverman is with us on the panel today, and he is going to give us 3 lectures in the next couple of months on his amazing correlation of the pathology, anatomy, and echocardiography. So keep tuned. We are going to have more things to come on Dr. Norman Silverman's series. And now I'd like to thank Dr. Rima for being the coordinator of this fetal series, and she's going to start. Thank you, guys. And please type your questions on the Q&A chat box, and then the panelists and the speakers are going to be very happy to answer you.
Hello, good morning or good evening, wherever you are. This is Rima Bader, and this is our 40th episode of the Fetal Series under Congenital Heart Academy and Gulf Heart Association. And we're very honored today to have a very specific topic that was asked by many, which is genetics in counseling, genetics in everything today. And our first speaker is Morris. And Shane is the medical fetal cardiologist.
There's a problem with the sound.
Department of
with the sound. Be careful how you...
Cardiology, Texas Children's Hospital and Baylor College of Medicine. And Shane, would you like to share your screen, please?
Sure, I can. Your sound was cutting out a little bit. Is mine okay?
Yes.
Okay. Hi, thank you guys so much for the opportunity to be here. I'm really excited. As Dr. Bader was mentioning, I am at Texas Children's Hospital in Houston, Texas. I serve as both the medical director of the cardiovascular genetics program, which is within cardiology, and as medical director of the fetal cardiology program. And recently, we just developed the first advanced fellowship in cardiovascular genetics in pediatrics in the US, I believe. And so I serve as the program director for that advanced fellowship. So there's going to be 3 of us from our team presenting today, talking about different aspects of fetal cardiac genetics. So I look forward to talking. I'm mainly going to be discussing subtypes and pattern recognition, what I like to call in our field deep phenotyping. So my disclosures are just that I do have some research grants. And the objectives of this discussion are to understand lesion-based common genetic diagnoses. So many people on the call are cardiology experts, whether you're a cardiologist, cardiology trainees, sonographers, and we're very good at looking at lesions and classifying lesions. And how can we use that knowledge we know about lesions to understand how those correlate with genetic diagnoses? We'll also talk a little bit about integrating prenatal diagnosis into personalized care, but that really is going to be more what Lauren and Josie are going to talk about, and talk about how codifying these phenotyping can help with research. And I'll just give an example of that near the end. So just to get us on common language grounds, we're going to be talking about phenotype and genotyping. So phenotyping, and I know most people know this, but just to go over it, is talking about what do we observe? What are we looking at on the physical exam, the clinical findings, the echocardiogram? An example might be our phenotype is tetralogy of Fallot with a right aortic arch, a congenital diaphragmatic hernia, hydrops. Those are all phenotypes that we're observing. Then there's genotyping. So genotyping is the genetic findings that we find. So for example, 22q11.2 deletion syndrome, also called DiGeorge, or a Notch1 variant. So those are the genotypes. So what we're looking for is genotype-phenotype correlations to help us understand and manage patients. So, I think Lauren's going to go over this in a little more, but just as a reminder, when we're looking at genetic variants in children with CHD, Most commonly, we see chromosomal rearrangements or chromosomal changes. This is going to be like aneuploidy. But then we can also have copy number variation. This is where small pieces of the chromosomes are missing or extra. So this is like 22q11 deletion syndrome or Williams syndrome, which is also a deletion of a portion of the chromosome. And what has been sort of in the last 10 years gaining a lot more attention is single gene disorders, which cause quite a bit of congenital heart disease, including Kabuki syndrome, Marfan syndrome, Charge syndrome, all the RASopathies. So these are single gene disorders. So we're looking at all three levels. So, and again, just as a reminder, these are some common conditions. And if you look at aneuploidy, these are chromosomal rearrangements or chromosomal problems. Those are best detected by a karyotype, but can be detected by a chromosomal microarray and can be detected by a FISH. Microdeletion syndromes or copy number variation is best detected by a microarray. In some circumstances can be detected by a FISH if you have a very specific FISH. So this includes conditions like I mentioned, including Cri-du-Chat and Jacobson syndrome. And this is a list of some common single gene disorders, and these will not be picked up by a karyotype or a microarray, but you have to do some form of gene sequencing. This might be a congenital heart disease panel, whole exome sequencing, or whole genome sequencing. So now we're going to move into cardiac phenotyping. So often when we talk about phenotyping, when you're training, we say, well, are the palpebral fissures down slanting? Are they short stature? Do they have a broad-based chest? But I like to talk a lot about cardiac phenotyping among cardiology experts. So for example, if you are reading an echocardiogram and you see this echocardiogram, you can see this is a parasternal long axis view. This is the mitral valve. This is the aortic valve. And we can see, knowing nothing else from the patient, that there is mitral valve prolapse, there's elongated mitral valve cords, and there's aortic root dilation. This is a really common phenotype in Marfan syndrome and Loeys-Dietz syndrome. So just from looking at the echo, we can tell that this patient has a high chance of having a genetic condition, regardless of the extracardiac exam. This is invaluable because conditions like Marfan and Loeys-Dietz often don't have the classic skeletal features when they're very young, but the cardiac features are usually present from birth. So the cardiac phenotyping is critical. If we look at this patient, this patient has asymmetric severe ventricular hypertrophy, and we can look at that and say, okay, well, if we saw this in a 2-month-old, that is so atypical. We can know, well, this is really unlikely to be classic hypertrophic cardiomyopathy that's seen in adults. This is probably what we call a phenocopy, something that looks like hypertrophic cardiomyopathy, but is different, like Pompey's or a RASopathy. And so a lot of these things we already know as people who are experts in cardiology, but making that transition to genetics is really important. If we see this patient, so again, we're looking at a parasternal long axis. Now, these are not fetals. The rest of my pictures are fetals. But parasternal long axis, you can see that here again is the aortic valve. The mitral valve is right off the picture. And this is the sinotubular junction and the ascending aorta. We can see that it's quite small. That is a really uncommon phenotype and is very specific to problems with elastin, most commonly Williams syndrome, which includes a deletion of the elastin gene, or just elastin arteriopathy, which usually includes a single gene disorder of the elastin gene, but causes this very discrete phenotype of supravalvar aortic stenosis. And this is another patient. So this is a patient we're looking for subcostal, has a large ventricular septal defect, has posterior deviation of the infundibular septum, causing subaortic stenosis, and they also have an interrupted aortic arch. You can see this is coming here. So this is an interrupted aortic arch type B with a VSD. And that has about a 70% chance of having 22q11 deletion syndrome. So we just talk about taking that jump from being an echocardiographic expert or a fetal echocardiographic expert to really understanding what genetic conditions are most likely. And a lot of times the external physical exam doesn't show this. And certainly on the fetus, we might not see all of the evident dysmorphisms. So this can be a major clue. So why do we do cardiac phenotyping and care about genetics? Well, we can improve the accuracy of a genetic diagnosis. We can also help guide prognosis and guide treatment. If we can say, I really think you should look for this, we can help advocate for prenatal testing. We can help warn parents about prognosis, and we can guide treatment if we think that their genetic condition might respond differently to a certain surgery or other intervention. So I also like to talk about deep phenotyping, which is important clinically and I think is important for research studies. So typical phenotyping, say that you have to turn in a form, you want whole exome sequencing, and the box says, what's the phenotype? Typically, you might put truncus arteriosus. The patient has truncus arteriosus. Deep phenotyping would be truncus arteriosus type 1 with a right aortic arch with mirror image branching and an absent right kidney. This provides a lot more detail. And so then when people go back to look at those records, if they use them for research or discovery or there's a new gene, they have a lot more information because it might be that only truncus with right arches have this problem. Or maybe it's when you have congenital heart disease and an absent right kidney. So working hard to do deep phenotyping can help both with gene discovery and further research, and I think is really important to help find patterns. So this is an example of why deep phenotyping matters. So this is a table, this is from Moss and Adams, looking at the likelihood of chromosome 22q11 deletion syndrome with different conotruncal lesions. Now we might just say tetralogy, right? But if you have tetralogy of Fallot with a left arch and normal branching, nothing else going on, the chance of a 22q11 deletion syndrome is only between 6 and 11%. However, if you add a right arch with mirror image branching, that doubles the likelihood that that patient has 22q11 deletion syndrome and also increases the likelihood that there could be another genetic condition. Now, if you say, oh, this is tetralogy of Fallot with pulmonary atresia, and there's MAPCAs, multiple aortopulmonary collaterals, that likelihood that there's a genetic condition goes up dramatically. So it's really important not just to put tetralogy to help interpret the test and counsel the family. So when we do phenotyping, you can do deep phenotyping, but you also want to group lesions to say, what family of genetics do I think this is? And we know that most congenital heart disease falls into natural groupings. And we know it's this way because we often see these run together in families or with the same genetic condition. And this has a strong correlation with genetic etiology, right? Like we've all seen families where one sibling has truncus and one sibling has tetralogy of Fallot, but they may not be 22q11 deletion syndrome, but we know those are in the same sort of embryologic pathway. So I'm going to go through the groups, how sort of I understand them and describe them and write about them. So there's the conotruncal defects. So tetralogy of Fallot, pulmonary atresia VSD, which is also tetralogy of Fallot with pulmonary atresia, truncus arteriosus, type B, interrupted aortic arch with VSD, and right aortic arch and double aortic arch. Transposition of the great arteries was classically in this group because it's a problem with the outflow tracts, but we no longer think embryologically it is a conotruncal defect. And you can think about that. If you've seen 22q11 deletion patients, it is exquisitely rare to see a transposition patient, and that's because it has a different genetic pathway. Okay, second is left-sided lesions. So we know we see these commonly together all the time. So bicuspid aortic valve stenosis, coarctation of the aorta, the most severe hypoplastic left heart syndrome, and sort of a mix, which some people call Schoen complex or multiple left-sided lesion or left heart hypoplasia or hypoplastic left heart complex, which tends to be, sort of significant arch hypoplasia with a hypoplastic aortic valve and a hypoplastic mitral valve, but not needing a single ventricle repair. There's endocardial cushion defects, so like AV septal defects, transitional and partial AVSDs, prime MASD, and cleft mitral valve. And we have laterality defects. So this includes heterotaxy, but also genetically includes dextrocardia. That's pure dextrocardia, not from congenital diaphragmatic hernia. Also includes double inlet left ventricle, both with normally related arteries and malposed arteries, and CCTGA. So we also know now that transposition of the great arteries is in this group genetically. So there are over a dozen papers showing families in which people have both CCTGA and transposition from the great arteries, and I'll show you some of our work which also emphasize this. There's also right-sided lesions like pulmonary valve stenosis and pulmonary atresia with intact ventricular septum. There's elastin-mediated lesions, so this is SVAS, often combined with branch PS and coarctation. They also have high risk of renal artery stenosis and mid-aortic syndrome. And cardiomyopathy-related, we're understanding that Epstein anomaly seems to really be a cardiomyopathy of the tricuspid valve and right ventricle, and the genes emerging that cause Epstein anomaly are mostly cardiomyopathy genes, not sort of in the traditional CHD pathway. So this is kind of the wheel. I'm always evolving this. This is the one we use at TCH, where we have the group of the type of lesion here and the postulated genetic pathway that's altered along with the lesion. So for example, conotruncal defects are caused by neural crest and second heart field abnormalities. Laterality defects are caused by abnormal cilia and left-right patterning. Right-sided lesions, we're still learning, but mostly rhasopathies. Elastin disruption causes the elastin arteriopathies. Problems with the dorsal mesenchyme protrusion alteration cause AV septal defects. And as I mentioned, cardiomyopathy genes seem to be causing Epstein anomaly. We don't understand septal defects as well. They're probably very heterogeneous. And left-sided lesions are constantly emerging. So the example, I'm just going to go through one of the reasons that deep phenotyping is really important. So if you put on the form, the patient has bicuspid or coarctation of the aorta, that is hard to know in isolation what it means. So if you look at the first box, if you have bicuspid aortic valve with transverse arch hypoplasia, a membranous VSD, and posterior malalignment of the infundibular septum, this is actually very close to interrupted arch type B and is very likely to be due to a 22q11 deletion and would be a conotruncal lesion because it's arch hypoplasia with a VSD, posterior malalignment, and happens to have a coarctation that was probably a secondary development. But if you have coarctation and it's only with BAV and valvular aortic stenosis, this is a left-sided lesion. The most common cause of left-sided lesions is Turner syndrome. So by doing deep phenotyping, we have gotten a totally different genetic condition that is highest on the list. If you have coarctation of the aorta, but you also have an AVSD, double outlet right ventricle, TPVC, and bilateral superior vein cava, this is very likely heterotaxy and a laterality defect. And one of the most common causes of this is a gene-caused nodal, or of course the ciliary proteins. And fourth, if you have coarctation of the aorta, but it's with supravalvular aortic stenosis and branch pulmonary artery stenosis, this pattern of lesions is most consistent with an elastin arteriopathy. So if you just write coarctation of the aorta, you might be missing what you're really looking for and not necessarily counseling the family as specifically as could be. So just to show you some fetal examples, I'm just going to go through a couple of groups. So first, we're going to talk about some conotruncal defects. So if you look here, this first one is tetralogy of Fallot. We have an overriding aorta. We have a pulmonary stenosis. This is an truncus arteriosus with interrupted aortic arch. And we have a very nice example of a double aortic arch. So these are all conotruncal lesions. So we think that almost all the etiologies of conotruncal lesions are abnormalities with the neural tube or second heart field. That's what this is, second heart field and cardiac neural crest abnormalities, and it causes disruption of this pathway so that we get these conotruncal defects. So the highest frequency in this group, as I've mentioned multiple times, is 22q11 deletion. Some people call it DeGeorge. Trisomy 21 is also quite common. If you have tetralogy with an AVSD, that is 80% chance that's trisomy 21. Trisomy 13 and trisomy 18. Copy number variants are also common, including the 8q12 deletion, which has the CHD7 gene, and 8p23 abnormalities, which have GATA4, which is important for all heart diseases. And single gene variants, the most common of which is charge. But we also see GATA4 and Alagille. So the second group I'm going to focus on is laterality, and this is a group I do a lot of work in and I'm very interested in. So this includes, again, heterotaxy, so dextrocardia, double and left ventricle, CCTGA, and TGA. And you see some examples up above of some of these. So we have a heterotaxy, we have a double and left ventricle, and we have transposition. So we know that most laterality defects are due from a perturbation of sort of the normal right-left patterning. And this requires both proteins like nodal and lefty that tell the axis to kind of go one way. It's kind of like a flight attendant and says, turn right, turn left, go this way. And if you don't have that direction, it doesn't work properly. And part of what guides these, besides these protein, are cilia that sort of pump the transcription factors the right way. So this is a paper we published last year about the gene caused nodal. So nodal is one of these important proteins that tells you kind of to go right. And if you're missing it, things don't go right. Now, but then the cells just have to decide, which way am I going to go? You might have a nodal variant and be totally normal, or you might have a nodal variant and have right atrial isomerism. So we described 33 families from Texas Children's Hospital that all had nodal variants, and we looked at all of their pedigrees, and we looked at closely, we did deep phenotyping on their lesions. Now, what's really interesting is in that whole group of 33, there were only 6 heart diseases that we found, and these were them. So this is a normal, just an example. But those patients with nodal variants had either DTGA, DORV with D malposed arteries, tricuspid atresia with D malposed arteries, CCTGA or L transition, DILV. We actually saw both types of DILV just for the drawing. We did L looped, but we did see both types of DILV and heterotaxy. Almost all were right atrial isomerism. There were a few situs inversus with CHD, no left atrial isomerism. So we saw that this is a very specific pattern seen in nodal variants and was really quite interesting. Another fact, I don't think I showed it. I didn't bring up the table here, but in most US literature, this is 2 to 3% of heterotaxy, but it was almost 13% of our population. And we realize nodal variants are enriched in the Hispanic population, especially the Mexican population, of which we have a lot of patients. There was one variant of the 33, 17 had the same variant, and it seemed to be a deep founder effect. So if we look overall at laterality defects, almost all are single gene defects. They're very rarely copy number variants. There can be the positioning genes like nodal. They can be ciliary genes. There's about 100. These are some examples. And the most important thing is almost all of them will be missed by standard prenatal testing, including karyotype FISH and CMA. You have to detect these on gene sequencing. So it's really, really important that they get gene sequencing. And if they only have standard testing, you're likely not to find a cause. This is the last thing I want to talk about is a really exciting paper that just came out, and it's looking at something called Diagnostic model. So what we looked at is could it be possible that we kept seeing patients that had heterotaxy and we would get 2 recessive variants. We get a recessive variant in one ciliary gene and a recessive variant in another ciliary gene, but both looked pathogenic, both looked important. And the question was, are these 2 recessive genes working together since they're in the same pathway? So what we did is we looked at variants that should be pathogenic, and we looked in a control population of healthy people. And we saw that about 0.3% of the 600 patients had what looked like to be a pair of pathogenic variants that were digenic. We looked in a public database called Kids First and said, okay, if we look in a population with congenital heart disease, how frequent is it? And it was definitely increased almost tenfold to 2%. We also looked in PCGC, and again, it was much higher, around 4%. Then we limited the cohorts to laterality defects. We looked at a laterality cohort we have of 247 patients and found that 3% had digenic variants. And we looked at just the laterality defects in these 2 populations, and there was 8% and 13%, so far above normal. So this supported the idea that these digenic variants are causing laterality defects. And I know this is hard to read, but let me just orient you. This is an example of the modal cilia and the immodal cilia. And what we've done is we've made little diagrams, little illustrations for each part of the apparatus for the modal cilia and non-modal. And this is a list of every case in our paper. And we use these little icons to say what part of the cilia is messed up. Or a few of them, there were other cardiac genes that weren't necessarily ciliary. But you see this is 2 hits to the outer ciliary arm. This is an outer and inner ciliary arm hits. And you can just see that repeatedly these are 2 hits to ciliary genes. And so again, I think goes supporting evidence that digenic variants are causing these laterality defects. So this is very exciting, and this hasn't been written a lot about, but I think we'll have a lot higher solve rate applying this technology. And there's some AI programs that can help you discern this now. So this is just an example. We looked in TCH over a period of a few years, and we looked at 3 types of heterotaxy: situs inversus with congenital heart disease, right atrial isomerism and left atrial isomerism, or asplenia syndrome and polysplenia syndrome. And we looked at what the solve rate was looking at copy number variants or sequence variants. And you can see that we only found 1 copy number variant, but we found quite a few sequence variants. So of the 5 patients who had sequencing with situs inversus, 2 or 40% were positive, and they were with ciliary genes. If we looked at right atrial isomerism, unfortunately, only 12 got sequencing, but we saw 25%, again, all with patterning or ciliary genes. And with left atrial isomerism, only about half got sequencing, but we solved 35%. Again, mostly with laterality and patterning genes and a lot of compound heterozygotes and homozygous. So very interesting to me. So basically, I look forward to my colleagues speaking too, but as a cardiology provider, what is our role in genetics? I'm not a geneticist. But I think we can help from our phenotyping. If there's a genetic condition, what's high on the list? When you look at the echo, what do you want to talk to your genetics provider about saying, like, I really am worried about DeGeorge. I'm really worried about Kabuki. How could this alter prognosis, delivery planning, intervention planning, family planning, and thinking about this early as a fetal provider rather than after birth? We also, I think it's imperative that we discuss genetic testing with every fetal CHD patient if it's possible. It's not just for termination decisions, but it can also help with guidance, prognosis, decision making, delivery planning. And I will say, I have found when it comes from a cardiologist, it often carries a certain weight. I think a lot of parents think that it's routine and they don't want to talk about genetic testing and this is just something that everyone wants. But if we say, hey, this really helps us understand what to do, I find that the yield is a lot higher of people getting testing when I talk to them specifically about it. Also, if a positive variant is found, if a genetic condition is diagnosed and families know this early, they can process that information before birth rather than when they're dealing with urgent interventions in the cardiac or neonatal intensive care units. And as Josie's going to talk about, testing is becoming nearly universal in cardiac ICUs, and it allows the parents to hear this information in context a little bit earlier. So in summary, about 30% of patients with congenital heart disease can be found to have a genetic association. I think it's really our role to understand this and have this be part of our typical language and thought process. There are patterns of CHD that help you understand the highest and lowest risk genetic etiologies. Almost all lesions are associated with genetic condition caused by chromosome anomalies, copy number variants, and single gene variants. So they almost all the spectrum of genetic conditions can cause any kind of heart disease. And given this, gene sequencing really needs to be considered, even though, at least in the US, it is not standard on amniocentesis, but it is a critical part of CHD diagnosis. And if we can do it either sequentially after the microarray or at the same time, I think it's very important. So I just wanted to thank our incredible teams at TCH. We have a huge fetal center team and a very large cardiac genetics team. And I look forward to answering any questions and hearing from my colleagues. Thank you.
Thank you so much. It's a very interesting talk, very high-powered one. I'd like to pardon my ignorance, Jane, but and you've shown lots of tables. One of them is zero chromosomal anomalies, right? In most of the so should we just ignore asking for a chromosome anomalies and go for sequencing, or what do you think?
That table was only for laterality defects. I think the yield is low in laterality defects, but karyotypes and even CMAs in this age are pretty low cost. I think it doesn't hurt to add it. I just would never do it in isolation and say we're done, especially for laterality defects because the yield is so low. But it is quite high yield in conotruncal defects and in AVSDs and endocardial cushion defects. And I think things are moving towards doing more comprehensive universal testing. And you'd hate to miss, a trisomy 13 or a DeGeorge, but I think people need to not stop at a karyotype or a CMA, especially in some of these in lesions like laterality defects.
Laterality is the one. So if you are just sitting in the lab in the clinic and you see the case of congenital heart disease, okay? From what we heard and what we know is that genetics is a lot into congenital heart disease, right? Mm-hmm. And we didn't do that before, but now everybody is tending to do that. So what would you click on the tests that you're going to ask for? Considering that we're talking worldwide and considering also the availability of tests and the yield and the cost.
Well, exactly. And I think you have to look in your own environment on cost and yield. Exactly. So, in an ideal world, I think because usually it's about, more or less half are going to get solved by CMA and half will get solved by exomes, by sequencing. In an ideal world, to me, it would be great if we get whole exome or whole genome sequencing in everyone. Even in my state in Texas, that's virtually impossible right away. And so we do a staged approach. So we have a consult service outpatient. And I don't know if I think Josie's mainly going to talk about inpatient, but anyone can come to us and we'll do the genetic testing for the heart disease. And so we also weigh, it's much more likely to be positive if they're syndromic. And so if cost is an issue and access is an issue, which it certainly is in Texas, we'll try to do the highest yield thing first. We'll look at the condition. Like if it's laterality, we're not going to send a CMA to start. We'll try to get everything. But if it's AV canal defect or if it's a conoduncal defect, we might start with a CMA. And if the CMA is negative, then try to do sequencing. Because if we find 22q11, we're not going to do further testing and we saved money. I think things are moving towards whole genome as the cost goes down, I think in the next 5 years. And I'm curious to hear Lauren and Josie's comments. I think we'll be there. But for now, I think you have to grade what's available and cost. So we often do a staged approach unless a sequence variant is extremely high. Like if we see a patient and we know this is Kabuki or we know this is an elastin deficiency, we'll go straight to a panel or exome sequencing. So that's why I think the phenotypes are really important while there's still cost and availability issues.
When you talk about deep phenotype, I like this. So are you trying to teach us, look at the echo and then look at the patient?
Yes, because I think
I got the message that you're looking at the mitral valve and you think this could be, and then the outflow tract. This is beautiful. So, I mean, what do you mean by that? So,
well, I think, we've always been taught to, do a phenotyping exam, right? Every cardiologist has done some genetics and you're supposed to look for, wide space nipples or hypertelorism. And we're okay with that. We're not great at that, but we are really good, almost all cardiologists, at looking at the echo and understanding patterns. And so I'm just saying that we need to realize how strong that is. A geneticist cannot look at an echo and understand the subtle difference between TET pulmonary atresia and PA-IVS. Like if they see that, they just see pulmonary atresia. They don't realize that those are dramatically different diseases, PA-IVS and PA-VSD. And so to kind of use our knowledge and our strength when you're talking to your geneticist and say, PA-VSD, I really think this would be conotrunkal. I really think it'd be 22q or charge. Or PA-IVS is much more likely to be a rhasopathy or not be solved. And so to use that knowledge, like we should always look an external exam on the patient, but there's no one else besides a pediatric cardiologist who understands the subtleties of the echo.
And sometimes it's just reading echoes, you don't see patients. So you don't know much about the patient. Thank you so much. Dr. Silverman, do you have any questions for Shane?
Yes, good. I do have questions. First of all, that was a brilliant talk, and thank you very much, Shane, for providing that for us. The thing that I think everybody would want to know is, can you give us a bibliography, publish a bibliography on the website as well, so that we can explore this in greater detail?
Sure, happy to share some references.
Okay. Any other questions before we proceed?
Looks like someone asked about DORV as part of conotrunkal defects. I can try to answer that really quick if we have a second.
Yeah, sure.
So it's complicated. When we're writing papers right now, we do put DORV as a conotrunkal defect, but my personal bias is that DORV is simply an anatomic description, not really a true fundamental congenital heart disease. And so like coarctation can be in many groups, I think DORV is the same. So I think TET-like DORV is probably a conotrunkal defect. I think DORV with malposed great arteries is probably a laterality defect. And I think DORV with mitral atresia is a left-sided lesion because we see it commonly in the left-sided lesion conditions. And so I think that it's probably anatomically there's something in common, but genetically I think it's different based on the coexisting lesions.
So, I mean, also, very famous. You're putting it out of the lists, right? I mean, we used to think that 22q has to be done in every congenital heart disease, especially the truncus and truncal and DGeorge. But actually, I haven't seen a DGeorge for many years now. But the fact that you see arch anomalies and the way you divided the arch is beautiful. So not any coarctation will be a truncal, right?
Right. Coarctation could be in many different categories. Yeah.
Okay. Now we have a question as well for you, and it says here, okay, where is it? Somebody asked about the age, okay, where is it? Excellent talk. One question, is there any genetic correlation with race? In Southeast Asia, we have more right-sided congenital heart disease.
I think there is. I think so. What was interesting in that, I think it's very unresearched, but in our nodal paper with all those patients, we only saw right atrial isomerism and not left atrial isomerism. And this right atrial isomerism was in the Hispanic community, and probably because of this one variant in nodal that was recurrent. And if you look, there's a paper from Kayla Lopez from, gosh, a long time ago when she was junior faculty that showed that in our population in Texas, we have many more heterotaxies than the rest of the US, that there's an increased prevalence of heterotaxy, and it probably was from the same thing. So I think there certainly could be that there's certain genes that are more prevalent due to founder effects in certain racial or ethnic or geographic groups that are more common. And I think we most of the research has been done in European descent families, some done in Middle Eastern families, and I think we just need to do more research to better understand this.
I think more collaboration worldwide. Genetics is like in here in Saudi, we have a lot of genetics that needs to be unraveled. What about the Pompe? I mean, we have families Pompe, but I haven't seen it in utero. So, I mean, why? I mean, maybe I'm wrong, but I've checked the patient that I think it didn't have anything, and then
Well,
the heart was so hypertrophic. But maybe, I mean, I don't know, but the defect is there in utero. It doesn't need to be. I'm not sure the enzymes, the deficiency is in utero already.
yeah, there's an early onset and a late onset form of Pompe.
We're talking
And
about
so
the
the
early
early
onset,
onset
prenatal
can
ones, yeah.
present in utero. I've had 2 cases. And Pompe is enriched in the African community. I forget if it's Ghanaian, but there's a very specific African country that's enriched for Pompe's, and they see a lot more. And both of my patients were from that community in Africa. And so I think, again, this goes to sort of a racial, geographical differences, that they're more likely to see that in utero if fetal testing is being done than populations that have less of that population.
So would you see the hypertrophy in utero?
You can. Both of my patients, I mean, they had the early onset form and had it in utero. And so it was really lucky that we diagnosed it, because in one family, a little girl had died of unknown causes, like at birth, I think at 2 or 3 months old. And then we saw hypertrophic cardiomyopathy. And the second, it looked like hypertrophic cardiomyopathy was Pompe's, but she was able to get on enzyme therapy, within a day of being born. And she's doing wonderfully well. She's 6 years old now. And so we were able to prevent the consequences with enzyme therapy.
So if we have family history of Pompe, so you ask that we should ask them to come how often to have fetal scans?
Well, it depends. You'd have to talk with your metabolic genetics team and see. I think there's some contemplation of actually giving in utero therapy and seeing how severe the hypertrophic cardiomyopathy is. But I think the biggest thing is at delivery, getting enzyme therapy to them as quickly as possible. I don't know how often. I don't know if there's been enough written to say they might have an in utero demise. It's more of just having careful delivery planning.
What I mean that you bring them at 20 and 30 weeks or so on, so that since you said you've seen them, I have done 2 cases, I haven't seen them, but probably it's a variant, or I'm not sure. But thank you so much for explaining that. And your neonatal one, yes, you have to start the enzyme therapy quite early. I think we should move to the next speaker. And I'm very, who's going to be next? Lauren?
I'm going to be next, yes.
Okay. Thank you so much, Lauren. Lauren is an assistant professor.
Rima, you're breaking up a lot, quite a bit.
Oh, I'm not sure why, but do you hear me now?
Yes.
Do you hear me? Okay. Come nearer to the mic. Lauren is a professor of genetics, Department of Obstetrics and Gynecology, Texas Hospital and Baylor College. We're so honored to have you today, and we're very eager to hear you. Thank you. Share your screen, please, Lauren.
Yes, I will. And I obviously have a very different background than Shane. So my primary specialty is genetics. And then working in the environment that I have, I've learned much, much more about very specific nuances with congenital heart diseases. Let me make sure that I'm hiding this panel here. There we go. But my primary interests, genetic counselors, we deal with both the medical and the psychosocial nuances. And so that's where the counseling comes in. So I'm going to touch on both of those aspects today. And my particular interests with both my clinical work and my research work are in this new era of genomic sequencing, what it can uncover about diseases, genetic diseases that have onset in the fetal sphere. So I do not have any financial disclosures. Mostly people do not want to pay genetic counselors a whole lot in terms of research and collaboration. So I'm going to be focusing on our risk assessment and diagnostic workup of the fetus with congenital heart disease, talking about some of the psychosocial and management considerations unique to this fetal context, and then also touch on some of the recurrent diagnoses and trends that we see in diagnostic yield in the literature, specifically for these fetal cases, because that can be quite different to what we see in the pediatric literature. So this would be a very typical day for me if you're in an environment where you maybe haven't worked with a genetic counselor before. So a patient, a 34-year-old patient in her third pregnancy, is referred at around 22 weeks and 6 days because an outside ultrasound had shown concern for a congenital heart defect. She previously had blood-based screening for some of the common aneuploidies, which had been low risk, and there was no family history of congenital heart defects. The echo with us showed hypoplastic left heart syndrome with mitral and aortic atresia, and then the ultrasound was additionally significant for a femur and humerus that were mildly short. So, kind of a soft marker type of finding rather than an additional true congenital anomaly. So when I go in to see a patient like this, I have a couple of critical considerations. I'm going to be assessing what is the likelihood of an underlying genetic disorder. So that goes back to Shane's comments about the phenotyping and looking at patterns. Absolutely. I need to look at patterns both within the heart and for the fetus as a whole. That's connected to the differential that I'm going to generate and discuss with the family. And when I'm thinking about the differential, what I'm also thinking about is what are the variable differences in the prognosis and the care needs for some of the conditions that might be highest on my list. Because that connects with the impacts on the management and the workup that I would be recommending to the family. Things like, how strongly do we need to have this information prenatally in order to make the best care plan? And, what is the family's potential management options that they're considering, such as termination of pregnancy, doing palliative care or maybe comfort care only, proceeding with trial of intervention after delivery, or going for, full high-level intervention. And we're also meeting the families at a very critical point emotionally in their pregnancy, because no one goes into pregnancy assuming that their child is going to have a severe health condition. So about halfway along in their pregnancy, which is when most of our ultrasound anomalies are detectable, they've now had essentially emotionally the rug pulled out from under them. And so some families that I meet may have had a couple of weeks to process this information. Other families, I might be meeting the same day that this is discussed. And that's going to impact how much the families can process and how they're going to think about and react to the information. So with that framework in mind, I'm going to talk a little bit about genetic considerations for congenital anomalies in general, as well as with cardiac anomalies specifically. But a very common phenomenon that I'll meet with my prenatal families is them to say, but how could this happen? No one in my family has anything like this. And they're a little shocked when I tell them, actually, that's what I would expect. Because when we look at the genetics of congenital anomalies, with the full workup that we can do, still about 40% will remain unexplained, even after all the testing that we could do. We have a big chunk, 30 to 40%, where it's a chromosome abnormality, whether it's a large change or a small copy number variant. A lot of those tend to happen what we call de novo, or new in that individual. They've not been passed down from any side of the family. And then when we look at our sequencing data, then you'll see that there's different inheritance patterns that can follow. And most of these inheritance patterns also are not going to be something that would show with any family history. With the autosomal dominant conditions, only one copy of the gene needs to be mutated. And again, when we're seeing fetally detectable presentations, many of these are de novo mutations compared to a pediatric family who might be coming because down through the generations, they have Marfan syndrome, or you realize there's been a couple generations of people with 22q deletion. We have a large proportion of recessive mutations, meaning both copies of the gene need to be mutated, and the parents who are only carriers of one copy will be perfectly healthy and have no reason to know that they're carriers. And then we do have a small proportion of X-linked conditions, again, which may or may not show a pattern in the family depending on who is a carrier and how many males have been born in the family. So this just to appreciate that when we're talking about fetal genetic diagnoses, many of them, this is going to be the first time that something's been identified in the family. And so one key thing to really emphasize as a genetics practitioner is that absence of a family history does not by any means mean that it's not a genetic cause of the heart defect in that fetus. And as Shane mentioned, it all starts with the phenotype. So in genetics, we really are going to use that to determine how we interpret genetic variants that might be found on these tests. Some variants are very clear-cut. They've been reported before, they're well characterized. You know, okay, we see this specific mutation in PTPN11. We know it's seen in hundreds of people before with Noonan syndrome. That's very easy to interpret regardless of the imaging findings. There are other cases where the variant may not be well described. There may be conflicting data on whether or not it's sufficient to cause disease. And the more phenotype information that we have, the better we can make the case for or against that to be our cause. The tricky part is that the in utero environment, it presents some unique constraints on phenotyping, and this embryological process of development is happening at a rapid pace, and not all features that could be detectable prenatally are guaranteed to be detectable at any given gestational age. So as an example, while a 22 or a 24-week ultrasound or echocardiogram of the heart is going to be very good for the major structural anomalies, most of my brain anomalies patients that I see, especially if it's anomalies with the cerebral cortex, that does a lot of growing and maturing in the late second and third trimester, or growth abnormalities. So we also have to keep in mind where we are in gestation in terms of sort of what's the maximum type of findings that we could possibly see. And that brings me to this concept of the isolated fetal congenital heart disease. I will stand on my soapbox since I'm speaking to cardiologists and say, we can never, ever, ever tell a patient that their heart defect is isolated when we're talking to them in the prenatal period. We can say that it is apparently isolated, meaning that we see an absence of anomalies in other body systems, but we can't say it is empirically isolated, because again, these restrictions on appreciating the full scope of the phenotype that may be present, or that you may be able to better evaluate with a newborn or a young child. So the tools that we have, primarily again, we're relying on imaging, ultrasound, echocardiogram, fetal MRI. And so we can assess primarily structural anomalies. Again, these are all imaging-based assessments, and the phenotype can evolve very rapidly as we progress further in the pregnancy. We have very limited assessment of dysmorphic features, which are often sort of cardinal classic patterns that help you with your phenotyping in babies that have been born. We cannot really assess any symptoms related to body system function other than by, associated downstream effects like hypertrophy of a cardiac muscle or extra amniotic fluid that may indicate a problem with swallowing. And unlike the neonate or the infant who has an uncertain genetic variant that is identified, we have very few supplementary evaluations that we can bring to bear prenatally to help further investigate an uncertain genetic variant. We really can't run biochemical studies. We can't perform CT scan. We can't do an EEG. And so studies in the literature show that prenatal imaging may miss up to 50% of findings compared to what you could appreciate on a fetal autopsy, postnatal imaging, or postnatal physical examination. So again, this is where getting as much phenotyping information as we can from the imaging that we have available is really critical in determining our differential and interpreting test results that we get. Psychosocially, this is very difficult for families. Families have conflicting priorities, and I really appreciate working with cardiologists like Shane who understand the importance of an interplay between genetic etiology and management and prognosis, because a lot of families that I will get when I talk to them about diagnostic testing, which we'll go over the procedures themselves in a minute, they all come with risks of miscarriage, risks of prompting preterm delivery. And I'm usually meeting with a family after they've had their echo and they've just heard all about how important it is for the surgical management for a baby to deliver as close to term as possible and to be as high of a weight as possible. So most of them are absolutely terrified of doing anything that will have any risk of preterm delivery, even if the chance of a significant genetic issue is, many degrees of magnitude, increased compared to the risk of that procedure. And sometimes families can have very much tunnel vision on the surgical management because maybe that's all that they can cope with at that time. But also because, many providers and many lay people just don't have a good understanding of genetics, or it's more abstract to them. They don't really understand, because this might be the first time that they've ever sat down with someone, really how that plays into surgery, risk of surgical complications, risk of other health issues that might need to be evaluated and managed in the early neonatal period, along with the surgical management. And so for some families, we really can't afford for them to have that tunnel vision. It's important to realize that they're also going through a grief process. This is what we call the loss of the expected child. They're processing that certain things they might have dreamed of for their child may not be possible, or that their life is going to look very different. And everyone has different strategies for coping with that. For some people, it's to seek out all the information possible. For some people, it's denial, and that might lead them to be sort of non-compliant with their follow-up appointments or have a very low threshold for how much they can acknowledge at one time. Guilt is very common with the families that I work for, particularly the mothers. Very common for them to say that they've been wondering if they did something to cause this to happen. And so for genetics, it's really important for us to acknowledge that we don't have any control over the genetic variants that we inherit from our parents or that we pass on, and that there's nothing that a pregnant woman could have done or done differently or avoided that would have caused or prevented a genetic change. And then as we've started to touch on, we have many, many challenges in equity of care. And, even though I work in a very large medical institution in a large urban area, in a first world developed country, I have patients who I can't do any of the necessary testing prenatally. And let alone when you take that to the broader world and you're thinking of those questions about, what's our highest yield test? How can we afford it? How can we make these important workups accessible to everyone who really needs them, regardless of where they live or what their resources are? So as my understanding is most of the group are exclusively cardiologists, you may not be as familiar with in fetal life, how do we have to go about getting a sample of the fetal DNA, and then what do we do with it? So when we're looking at the fetus, we have several possible areas where we could obtain a DNA sample. The best for us is the amniotic fluid, because that has shed cells from the skin and the epithelial lining of the gastrointestinal tract. So these are cells that have come directly from the fetus and best represent the fetal genetic status. That's very important for chromosome abnormalities. That's less important when we're talking about single gene conditions. We can get a sample from the placenta. Oftentimes, if there's no amniotic fluid, or if we're very early in pregnancy, such as in the first trimester, we'll need to get a sample from the placenta. There can be sometimes, again, when we're talking about chromosome issues like trisomy 21, trisomy 13, trisomy 18, sometimes you'll find ambiguous results from the placenta. You'll see a mixture of trisomic cells and normal euploid cells. And then you still have to go and test the fetus with amniotic fluid, because you don't know, are these abnormal cells limited to just the placenta, or do they also correlate with the genetic status of the fetus? We can also get a sample from the umbilical cord. We have to be a little bit careful there to get maternal samples, because you're going to see a mixture of maternal and fetal cells as they're connected. They share a blood supply through the umbilical cord. And then in cases of fetal demise termination, we can also get samples from fetal tissue directly, usually from a central location, such as the butt or the thigh. We'll have the best quality of DNA in those circumstances. So these are overviews of the procedures. All of them, chorionic villus sampling, amniocentesis, and chordocentesis, involve typically an abdominal approach, where under ultrasound guidance, a needle is guided through the maternal abdomen into the uterus to collect either that small biopsy of the placenta, of the cord blood, or of the amniotic fluid. Again, with products of conception, that's again usually after, that's going to be delivery of the fetus. Depending on the placenta location, you may need to do a cervical approach with a catheter if the placenta is very sort of low lying or against the back wall of the uterus. So I've just presented here some of the risks of delivery, and I use the word delivery because it could be a miscarriage or preterm delivery depending on the gestation with that. So now that we have our fetal DNA, we have different diagnostic tools. I've ranged them from more specific to more broad testing. And oftentimes in fetal diagnosis, we're going to go more broad because it's rare that, we have a fetal phenotype where I say, I know exactly what the diagnosis is. I know exactly which one gene, for example, or which one copy number variant I think it is. I usually have a list of at least 2 or 3 possible conditions that could fit with what we're able to see prenatally. So primarily we're using chromosome analysis, gene panels, microarray, and exome or genome sequencing. at least in the US, no one really does FISH for prenatal diagnosis beyond FISH that can look for the most common aneuploidies. And that's because in the modern age, you'll get these other tests back much fast. I'll get a microarray back much faster than I'll get a 22q 11.2 FISH back. And understanding that, I'm the genetics sort of nerd in official genetics nerd in residence, other than Shane here, just in terms of what you can pick up from microarray versus exome or genome, the metaphor that I use with my patients is that of an instruction manual. So a karyotype will tell you if all of the chapters are there or if a big piece of a chapter is extra or missing. It'll also tell you how the chapters are arranged in the instruction manual. So chapters here are the individual chromosomes. A microarray will be able to check for any extra or missing chapters, pages, and paragraphs, but it won't be able to tell you how they're arranged within that instruction manual. And then the individual instructions or the genes, if there's a change there, it's more like a single letter spelling mistake. And so you need tools, the tools of gene sequencing to do that letter by letter spelling check throughout the genetic code. So until whole genome sequencing, which can detect both structural, copy number, and single nucleotide variants all in one test becomes accessible, orderable, covered by insurance at scale, usually we're using a combination of tests, like Shane alluded to, that stepwise approach based on what our differential looks like. So lastly, I'm going to touch on some updates from the fetal sequencing literature. So typically this has been either exome or genome sequencing, looking into what are our diagnostic yields. And, I think, we'll all appreciate that the chromosome abnormalities associated with various congenital heart defects are pretty well understood. And so that's why I'm not focusing so much on those, but really where are new discoveries happening and where are we really building our knowledge. Also, when we're thinking of fetal sequencing, we also have considerations such as a phenomenon called phenotype expansion. So that may be, broadening the different features that are recognized to be part of that genetic condition. A way that plays out in the fetal life is we have a much more enriched population for the extreme ends of the spectrum in terms of a genetic finding, because those that are described in the pediatric or the adult literature have survived long enough to be, in that literature. And so we do see enrichment in fetal sequencing for extreme phenotypes, the extreme end of the spectrum of that particular disease that historically have not survived, especially before we had all the advances in the surgical repairs of the heart defects, as well as different types of genetic variants that have a more detrimental effect on that gene than the ones that were, again, historically captured. We also have this lethality divide where there are some genes that they're so crucial to early development that they're so intolerant to genetic variation that if you have a harmful mutation, that is going to be embryonically lethal. So you may only ever see a 12-week or 16-week or 20-week fetus with that mutation in that particular gene, and you will never see them on the other side of the delivery room live born. So these are, I've selected some of the big heavy hitting papers and also some of the most recent papers to just give you an idea. Most of these cohort studies were either the prospective, not prospecting, prospective, or a meta-analysis, which was done a couple of years ago, looking at many different exome sequencing and genome sequencing studies. So you see that, again, I've put isolated in quotations. These are only a fetal congenital heart defect was detected on prenatal imaging. In known chromosomally normal fetuses, anywhere from maybe 11 to 15% of the time, these quote unquote isolated fetal heart defects will have a diagnosed, a known pathogenic or likely pathogenic genetic variant. So these are your firm diagnoses. And then if you have a phenotype where you have a congenital heart defect in the context of other systemic, either other congenital anomalies or just abnormalities of that fetus, like growth restriction, polyhydramnios, oligohydramnios, the rate of diagnosis significantly increases to, on the high end, maybe 29, 30%. So the prenatal seq, just don't cite that elsewhere for now, because we're currently having that submission pending of the manuscript, but I'm allowed to present some of the information. And then this paper from 2025, I just highlighted because it was a retrospective cohort. And so that means that there might be some bias in what they were clinically able to do. And you're more likely to get things covered by insurance if you have a very high suspicion of something genetic going on. But this is really just to drive home the rates of diagnoses. And in particular, again, we cannot dismiss those apparently isolated CHDs. We've also seen in the sequencing literature certain diagnoses that can have congenital heart disease popping up recurrently, meaning, you know, a lot of these papers, you may find an individual gene or diagnosis one time or two times, but these might pop up 5, 6 times in an individual cohort. So specifically Noonan syndrome, again, many times this will be a new mutation in that fetus. There are 12 main associated genes, but I've listed the most common ones here. Other features that we could appreciate prenatally that might make us suspicious of Noonan or arrestopathy in general include effusion anomalies like cystic hygroma, nuchal edema, hydrops, specific lymphatic anomalies, growth restriction, short long bones. And by this, I mean, not that would make us think of a skeletal dysplasia or a dwarfism condition, but mildly short long bones. And then low set or rotated ears can be appreciated. Kabuki syndrome has also been brought up. Even among genetics, the pediatric geneticists are having to understand that the phenotype that makes us suspicious prenatally for Kabuki is a lot different than what might make them suspicious in a pediatric case, because we see much more enrichment of those with the severe congenital anomalies. So that pattern of a congenital heart defect, especially a left-sided lesion like hypoplastic left heart syndrome, and then if you add in a renal anomaly like a horseshoe kidney, and the fetus is chromosomally normal, Kabuki is going to be one of the first things on my mind. And then a new one that's come out, which is not as much of a sort of classic one that you might have learned about or heard about, 5, 10 years ago, is cardiac urogenital syndrome. The gene there is MYRF, M-Y-R-F. Many times it's also de novo, but you can see very significant variability between family members who all have the same mutation. So, for example, I had a family where, the fetus was affected with some congenital heart defect and a diaphragmatic hernia, but not a severe heart defect. And then the variant was maternally inherited, but the mom was apparently fine and healthy. But then when we did the echocardiogram, we found that she had patent ductus arteriosus, which hadn't ever been diagnosed. And she had a brother who had hypoplastic left heart syndrome and died, and we suspect that he might have been affected also. So some of these apparently healthy parents may have very subtle features of the condition that just have gone undiagnosed. So with cardiac urogenital syndrome, as the name suggests, other prenatally detectable features can include both abnormalities of the internal and external genitalia, renal anomalies. You can see pulmonary hypoplasia even if you don't have a diaphragm defect. You can see congenital diaphragmatic hernia and sometimes microphthalmia. So these are some heavy hitters in fetal cardiac disease that we see more commonly when we do make single gene diagnoses. I've also provided some references, and I'd be happy to send that list to the organizers of this meeting if that would be helpful. And then for various and sundry inquiries outside of this exact meeting, I would obviously welcome anyone to reach out to me by email.
Thank you so much. It's such an important talk. Can you hear me clearly, or
Yes.
okay? I mean, I've learned quite a lot. I'm sure the audience are also learning. Could you go back to the slide with the yield, because I think this is very, very important.
Yes.
And tell us more about the table of contents. I like the way you sort of taught us what's the difference between sequencing, the yield of this and the yield of that.
Yes. Let me re-share here.
If you could go through that again, that would be great.
Yes. Yes. Sorry, when you get so many windows up that you lose track of the tabs. Okay, you can see the diagnostic yield table now.
Not this one, the one before were not this one. You have like the yield of each test, what you get from each test. Before that one, yes. Can you tell us more about this slide? And you said this is like when you're looking at the book for the first time. Can you tell us more about that?
Yes, so a chromosome microarray, you know, the biggest thing between a karyotype and a chromosome microarray is both a karyotype, you're getting an actual picture of the chromosomes and how they're laid out. So you can see very large deletions or duplications, like maybe half of a chromosome or a whole copy extra or missing, or if you have a situation like polyploidy where you have a whole extra set of all of the chromosomes, so triploidy or tetraploidy. Microarray is giving you a relative comparison along the genetic code of those sections compared to each other, sort of a dosage. So things that show a lower dosage compared to the surrounding regions, you would suspect a deletion. Things with a higher dosage compared to surrounding areas, you would suspect a duplication. But it's just showing you a data plot like that. And so
and in the book, and looking at the book, what was similar to what when you said?
So this is similar to like a microarray can tell you, you know, hey, half of chapter 1 is missing. Or
okay.
There's a couple paragraphs in chapter 14 that are duplicated, but it can't tell me, for example, oh, these couple extra paragraphs of chapter 14 actually come at the end of chapter 13 because of a translocation. And that has big impacts, not so much for the management of that fetus directly, but on the family's recurrence risks to have a future child that's affected.
And then the sequencing will be next, because that will tell us which paragraphs are missing in the book.
Can you put up your last slide again with the references? It was on for too short to me appreciate.
Yes, I will in just a moment once we get through this question for sure.
Okay, so exome sequencing will tell us about which paragraphs in the chapter are missing, right?
So exome sequencing is much smaller changes. So paragraph level is where microarray stops. And then things smaller than that, you need a different methodology to sequence, and you're generating little fragments of the letters of the genetic code. You have a reference sequence that you're going to align them to figure out where they go. And then you can see if, you know, we know what the sequence should be? And then we can check the sequence that we're getting from the patient and see, oh, has there been something like a single letter spelling mistake? There should have been, instead of saying, the cat jumped, I don't know, cat jumped over the box, right? A
Okay.
single letter spelling mistake would be the rat jumped over the box. Very different animal.
So looking at this now, this will teach us that you have to go step by step ordering, right? Chromosomes first. Do you agree to that? And then microarray, and then sequencing, and then WES?
So
Or this is not the rule. It depends.
This is not the rule. Our typical workup where we are is because a microarray will tell you like 99% of the information that you really want to know about the chromosomes. We start with a microarray, and oftentimes we'll order a very limited chromosome analysis at the same time just to tell us how things are laid out. But it's also very reasonable and appropriate to skip the karyotype and go just to microarray, just understanding that depending on what the microarray shows you, you may need to follow up with a karyotype if it's something like a trisomy or something like an unbalanced translocation. And you need the karyotype is what provides you that recurrence risk information for the family for those larger chromosome changes. And then our step 2 is usually some type of sequencing. Right now, there aren't many laboratories and there are not many insurance companies in the US that will cover fetal whole genome sequencing. It's easier to get covered in the pediatric realm. So most of the time we're either doing exome sequencing. That's kind of our first step, unless we have a very, very specific phenotype like heterotaxy, where there's a good panel that captures all of the genes that we would want. Again, usually we need to go more broad and see what shows up, rather than restricting ourselves to a limited number of genes and potentially missing the one that is causative. But there are some indications, like I said, like heterotaxy, where I can get what I need to with a panel.
So if I say, okay, let me go to whole exome sequencing and skip everything. Is this correct?
No, because exome sequencing, it's such a zoomed in view that it can't pick up those bigger arrangements. So if I have heterotaxy, for example, like Shane mentioned, it's usually a single gene defect. I will go to a panel, I will go to gene sequencing, and then as a caution, I'll do a microarray at the same time, but I'll be expecting to find my answer most likely on the sequencing. When you have multiple anomalies and heart defects, it's appropriate to start with a microarray because, chromosome abnormalities as a group are much more common. And then to go to sequencing of some sort if the microarray is not diagnostic. And in the US, many insurance companies will require us to prove that there's no chromosome abnormality before they will approve sequencing.
So basically, microarray is very good in yielding the information. Plus chromosome, basically,
Right.
because I've listened to a lot of geneticists. They like microarray quite a lot,
Yes.
and sometimes they say don't jump to sequencing. So the baseline is usually a microarray rather than anything else, and then from there we can ask the geneticist advice. Thank you so much, and this is very, very, very important. And I like what you said so much when you said that the heart, when you counsel parents, say it's not an isolated defect.
Yes.
I think this is a beautiful message, that because we don't know, right? We don't know.
Right. And I
Although you have a scan, before referral to cardiologist, there's usually extra cardiac scan.
Yes.
And this is normal most of the time, but still I think you cannot say this is an isolated defect, right? Because we don't know anything about the brain, we don't know anything about, I don't know. Do you agree to that? So in counseling,
Yes.
we can say, I can talk about the heart, but I don't know anything
Yeah. You can,
about others.
yeah. Oftentimes with my patients, I will say, Right now, the only thing that we're seeing is this heart defect. However, prenatal imaging can't detect all health or developmental changes that someone might have. So there's always the possibility that we could see additional findings in the future. Or I'll use the say again, apparently isolated and not just objectively isolated, because that's making an assumption that we really can't afford to make. Because sometimes families also will say, well, my provider told me this is isolated, so that means it's not genetic, right? And then I have to do a lot of work with the counseling to get them to understand how something can look isolated on imaging, but it may not be isolated from in a systemic way or from a genetic way.
Norman or anyone else from the panels would like to ask questions to Lauren, Joanna, and Facher or Shane? Anyone else?
Yeah,
I've already asked my question.
Sorry.
Thank you. Thanks for the reference.
Yes, Joanna.
Thanks for both lectures. They are really excellent, because I remember even, let's say, 10, 15 years ago, we used to say to the parents, it's heterotaxy or transposition. We don't have to do any genetics because this is isolated defect. And now we know that it is not. But the question is how important it is for the parents, apart from the future that it can be genetically transmitted, yes? Does it make any difference of treatment and results if we have transposition or heterotaxy, apart from the complexity of heterotaxy? If we find any abnormal genes, so we find find them, or if we don't find anything?
So I think heterotaxy is maybe not the best example of something that's really important to get that diagnostic testing prenatally, because our immediate management is all going to be informed by the physical abnormalities. Again, usually heterotaxy related genes, they're going to affect physical development in terms of left-right body patterning. If they happen to be as part of a primary ciliary dyskinesia, you're also at risk of childhood onset respiratory findings, which can include neonatal respiratory distress. But again, it's not going to have the same effect as like, okay, we have a child with hypoplastic left heart syndrome or a very complex heart defect that needs single ventricle repair, and suddenly we diagnose Alagille syndrome. That's going to be a much more significant effect on management. Or this is a female fetus with left-sided heart disease, again, single ventricle palliation, but we diagnose Turner syndrome, and we now know that the mortality and the morbidity is like nearly the opposite of what the standard counseling is for.
Yes, okay, no, it's obvious. However, if there is the single gene defect, does it matter for the future of this patient? Because usually we don't know it before the child is born, because if it matters before genome sequencing, we have to wait in Poland for a few months. So usually we don't have the results before. But if we have this result positive, does it matter in counseling for the future of the baby?
Yes, it absolutely does, because again, you may reveal that there are other medical issues that may present in the immediate neonatal period that you could not have prepared for otherwise based on the prenatal imaging. So I know that I don't want to encroach into Josie's time, because I know we still have her presentation, but yes, when I talk with my patients, my immediate focus, unless they're going to be terminating, is fetal diagnosis gene sequencing is directly and importantly informative for the best medical management of that patient in both the short term and the long term, because you don't know what you're going to find always.
Okay.
Yeah.
Thank you so much. And we have still, we can wait till the end and then we ask all the questions. I'd like to present our last speaker, but not least, and Josephine, Martin Chian, and talking about consideration for newborn genetic evaluation for the child with congenital heart disease. She's the co-lead inpatient cardiovascular genetics service, Department of Pediatrics, Division of Cardiology, Texas Children's Hospital, and Baylor College of Medicine.
Thank you. Let me share my screen. Okay, are we seeing my slides?
Yes, thank you.
Okay, thanks. So yeah, Rima did a great job. You handed out the title of my slide. I have no disclosures, and the objectives of today, we're just going to talk about the clinical utility of searching for a genetic diagnosis during the newborn period, and discuss the process of evaluating a newborn when we're concerned about a genetic condition, recognizing the limitations that come with trying to establish a genetic condition in newborns, and then we'll discuss our inpatient genetic cardiovascular genetic team consultation model at the end. Oh, sorry. So what's the clinical utility? As we've mentioned many times, genetic etiology in congenital heart defect can be identified in about 20 to 30% of CHD. And the more we test, I think the more we'll find that that number could be increasing. Genetic etiology does influence both disease management as well as surgical decision-making and surgical influence. So the types of surgical procedures or catheter-based procedures that they may decide to perform. It can identify associated anomalies or risks for the future for that child, as well as a recurrence risk in the future. Briefly talking about how does this impact care and counseling. Recurrence risk, of course, other types of associated risk or anomalies and altered outcomes. So I think we're pretty familiar with that. Tetralogy of Fallot is certainly associated with 22q deletion syndrome, also known as DiGeorge. But we've also learned that if that child has those two coinciding conditions, they tend to have a longer bypass time during repairs. And that certainly can lead to a longer intensive care length of stay. And then, of course, we're aware of the significant mortality that comes with individuals with Turner syndrome and HLHS. And then, altered outcomes, I just like to highlight that in children with Williams syndrome or ELN deficiency, they have a 25 to almost 100-fold increase of sudden cardiac death with anesthesia. And if we review this photo over here in the corner, it's because they have coronary osteal narrowing as a result of that ELN deficiency. So knowing that ahead of time, or presuming that we're concerned about that certain single gene deficiency ahead of time, could allow us to take certain precautions when we're placing a child or a newborn under anesthesia. So certainly knowing about genetic conditions impact the way we care for these children. Moving toward the evaluation of a newborn, which seems straightforward, but we're going to talk kind of into the nitty-gritty of it. I'll talk about my general process of it as I approach these children with congenital heart defects. Seems simple, but we do perform a head-to-toe assessment. It does go quite in depth. We're noting any birthmarks they may have. We're noting any dimples we find, particularly in the sacrum area. We're noting their hairline. We're noting the shapes and depth of their fingernails. We are noting their symmetry. We're noting how many fingers and toes they may have. We're noting whether or not their ears are in the appropriate position, whether their earlobes are appropriately formed, or if they appear to be in a normal shape and size, and whether or not they're posteriorly rotated or straight up and down as we expect them to be. We're looking inside their palms to see if they have the appropriate number of creases that you should anticipate for an individual. We're looking at their finger pads to make sure they are appropriately developed. We also take a chance to look at their anthropometric data when they are born. So their birth weight, their birth length, their head circumference. We want to make sure that they are the appropriate size for what we presume their gestation to be. Anyone who is too small or too large can help us lean one way or another of whether or not we're considering a higher chance of there being a genetic etiology of their cardiac condition. Backing up just a little bit, we are only evaluating children with a known, presumably isolated cardiac condition. That's who I'm talking about here. This is that patient population. We also are interested in any extra uterine findings. As Lauren has mentioned, we never presume that they are isolated CHD because we know most children will have other types of imaging outside of what was done fetally if it was identified fetally. So they tend to have a chest x-ray. You can learn a lot about a chest x-ray. You can learn if there are any rib anomalies or skeletal anomalies. This bottom photo here, they actually have butterfly vertebrae as opposed to the normal vertebrae on the top photo. And butterfly vertebrae can really clue into a condition like Alagille syndrome. If they have too many ribs or not enough ribs, if the ribs are the wrong size, if they're asymmetric, you can see if the liver is on on the appropriate side of the body. So a little bit of laterality can come into play. Newborns are so small that you tend to get the top of their abdomen in a chest x-ray. Sometimes you're lucky and you get a full chest abdomen film to look at. Tend to have some ultrasound imaging as well of the abdominal organs that you get to look at. So that allows you to see if there are any renal anomalies. Any individual with a cardiac defect and a renal anomaly raises your suspicion quite high for a genetic etiology. We like to look at their blood work. Calcium levels are quite important to us. Both high and low can influence our decision in what type of worry we get. And then bilirubin levels as well. And then obvious dysmorphisms, as we've mentioned. So upslanting palpebral fissures, if they have a cleft lip or palate, rocker bottom feet, those things are more associated with syndromes, which we would be likely to find on a genetic test and could help establish a genetic diagnosis for a child. Upslanting palpebral fissures, we highly associate with trisomy 21. Rocker bottom feet, we associate it with trisomy 13 or 18, and those are all common aneuploidies. We would identify those on either a karyotype or a CMA. Really fleshy ears and hyperteliorism or far spread across eyes, that we would associate with Noonan syndrome, and those we would identify on either a single gene panel or an exome. So their physical exam is quite important to us. And here are just some assessment pearls that I've learned along the way. Take note of what we've identified during the fetal life. So had they had swelling in the fetal life, were the fluid levels of the amniotic sac low or too high? Did they have issues with their neck during the fetal life? Don't skip the fingernails. Don't skip the back of the child's neck. It is a lot of hurry up and wait. We do like to wait on those extra diagnostic imagings beyond the echo. So we do want to know what their abdomen looks like. So we do want to know if they're getting a head ultrasound or a brain MRI, because we want to make sure that those scans are normal. Any abnormalities in those extra cardiac scans, of course, will raise our suspicion, but will also allow us to tag in our partners within the larger genetics team of our hospital to help us facilitate the best tests for those children. Always recheck the palate to make sure that that's intact. It's one easy test. The ears, truthfully, are like a fingerprint in individuals. Everybody's is unique and different, but certain individuals with certain conditions tend to have more similar ears, such as Noonan's. If you can appreciate this ear on this child over here, it's quite fleshy. There is a lot of extra skin in the top and in the bottom. And this is an individual who, this newborn has Noonan's syndrome, that have extra loose skin on the palms and on the heel. Their eyes are quite far apart. Their nose is short and upturned, and their head is a little frontal bossing, meaning they have quite a large forehead. And this is what you could expect someone with Noonan syndrome as a newborn to appear like. And then I ask you all as cardiologists to lean on your pediatrician training. So dive back into that full head to toe assessment that you learned when you were learning to be a pediatrician, and really take note of everything that you anticipate a newborn to look like. It's also helpful too if you're not sure whether the child appears different or if they just appear to maybe resemble their other family members. So we do tend to ask, do they look like their siblings, or do they look like mom or dad, or do they maybe don't look like their other children? And parents will be truthful with you. They'll let you know. They're like, actually, we're not sure who they look like, or they don't quite look like our other children. Our other children had stark black hair, and this one has really thin, wispy hair, and we're not sure. So it's a loose and relaxed conversation we try to have with these families to let them know, hey, we're just trying to see what your baby looks like. We'd like to know every little thing about them. We're going to count how many toes they have. We're going to make sure they have any birthmarks. We're going to note them down. We're just looking at every little thing they can tell us on the outside, because that's kind of all we get to know about them at this stage in their life journey. Now, moving toward the limitations, as I mentioned, because all we get to know about a newborn is what we can see. Limitations, I'm going to start on the right side of the screen with regards to evaluation. The dysmorphology, of course, it can be challenging. They are newborns. They all come out a little smushy. I know that's a really technical term, but they do. They all come out as though they are a little puffy, was stuck in fluid for 9 months or so, a little edematous, maybe beyond, some are beyond the normal newborn edema. So it can be a little challenging in that. I think as you do that over and over and over again, you get familiar with this is a normal newborn puffy eye, as opposed to this is an abnormal periorbital fullness that I'm suspicious for, particularly maybe Williams syndrome. Additionally, as a newborn, they may not have many symptoms of a genetic disease. We've mentioned early onset and late onset Pompe. If they have late onset, we may not know. We haven't had time to have that enzyme disorder or storage build up in their body. So we may not be able to see anything at that stage. Also, the limited diagnostic imaging that we may or may not have available to us. We may only be able to work with one X-ray and one echo. Maybe that's all that child has had and anticipate having in their short stay with us in the hospital. So we work with what we have. We work with what we know about the child on the outside. And developmental status, we don't really ask newborns to develop very much beyond what we anticipate them being allowed to do, beyond breathing on their own and having the suck, swallow, breathe reflux. So those are some barriers with regards to the assessment. Moving over to some barriers we can have when we're facilitating the actual testing or providing or consenting genetic testing within the hospital group itself, and with the conversations we have with the parents. Often there can be a little bit of a communication breakdown, either amongst our team, the primary team, maybe not necessarily notifying us that the child has been admitted or is born, or maybe needs a consultation with our team to discuss genetic testing. There is also the opportunity parents can feel hesitant to genetic testing, to either pursue it, or they may feel guilt if they do pursue genetic testing and they find there is a diagnosis. They're worried that they'll feel guilty that they pass this down to their child, even though we know that there's nothing they could have done to make that happen. And we try to facilitate the support that that's not their choice, but we do support their decisions should they ever not want to do that. Short stay hospitalizations tend to be a barrier with regards to insurance. So any stay under about 48 hours, at least in our state, gets a little tricky with insurance approving a genetic test. It is technically approved for all newborns in a NICU to undergo genetic testing. However, if they're only expected to stay for particularly maybe under 48 hours, the insurance companies could review that hospital stay and say, this child was only in the hospital for 2 days. Why did they have this large genetic test, regardless of which test it was, be it a CMA or an exome or a panel? And they may not approve that, and they could shove the bill over to the families, and those bills could be several thousands of dollars. So we try to avoid that at all costs. And if that means referring the patients to us and for an outpatient evaluation, we will certainly do that. And then also lab priority, often genetic testing is a low priority for patient care. And so sometimes our labs become the lowest priority, and sometimes they get missed. And we have to remind and badger the teams to draw our labs for us. Okay, gonna delve into our personal experience with regards to our inpatient genetic counseling team. Why we did this. So we had noticed there was certainly a care gap. Texas Children's has expanded significantly, I would say, in the last 8 years, if I'm doing my math right in my head, which I'm probably not. We have a significant size heart center, and we have a dedicated unit now for newborns with congenital heart defects. It's a 12-bed nursery, or NICU unit, sorry, which is constantly admitting and moving children with newborns with heart disease, whether it's isolated or not. That's neither here nor there, but also other parts of the hospital admit newborns with heart disease. And so we were seeing a large influx of patients with those conditions. Our genetic service, which services the entire Texas Children's Hospital, which is searching it the other day, is an over 900 bed hospital. They had seen a rather large increased burden to their plate trying to facilitate the testing for those children once that nursery was added on. And being that we had already, expanded our care team to adding in a couple APPs and a few more MDs, we saw an opportunity for our team to expand our role within the Heart Center and implement a specialty service within the Heart Center of an APP who's myself and one of my genetic counselors, who's Emily, she'll be on the panel later, to facilitate genetic evaluation and consultation and testing for those children, particularly newborns, with isolated congenital heart disease that were admitted to TCH Heart Center. Initially only the Heart Center in the beginning. We've now expanded to some other areas when we're consulted, and provide consultation and evaluation and testing for those children. Our numbers are honestly kind of surprising, but we've recently pulled the numbers for the past year, and we've seen almost 130 patients from August to August for the past 12 months. And just in the past 2 weeks, we've seen about 7 or 8. So those numbers will constantly expand. And the cute darling that you're seeing on these pages is my nephew, who his mama and dada gave us permission to use his face. So our pilot model that is constantly evolving, we work to establish a care team, which is myself. I am a advanced practice RN, so I have my master's training as a nurse practitioner. I have a special interest in cardiovascular genetics. I don't, beyond a special extra courses in my master's program in clinical genetics, I don't have any other formal type of training in genetics. I just have always had a special interest in it. And then Emily obviously is our genetic counselor, who too as well has an interest in cardiovascular disease processes. We identified our patient population, which is isolated congenital heart disease. We felt comfortable assessing those in infants, variant interpretation for those results and disclosing those results. We formulated our workflow, which is triaging the floor, our nursery floor, and figuring out which children were isolated based on what we know about them the day that we can look on their floor, and then round once weekly and try to see as many babies as we can. We try to speak with the families at the bedside if we're able to, if they're there. Most of the time they are. And then we, sorry, I got lost. And then we worked to disseminate that information of our plan to all of our teams that needed to know about it. So there are a lot of specialty teams within the TCH Heart Center as a whole. So the first team, or the frontline team that needed to know, were our intensivist or ICU team. We also needed to incorporate our cardiologists or cardiology service, because they are regularly within the ICU. And then we have some other subspecialists like our heart failure team and our electrophysiology team. We also work closely with them as well. And within those departments, we have trainees, because this is a teaching hospital. So fellows and residents, other APPs, students, trainees, that we are constantly introducing ourselves to and letting them know what we do. How do we reflect ourselves in practice? So it's truly a full consultation. We do an entire H&P to the best of our abilities. We review all of the diagnostic imaging available. We do a full head to toe exam. Thankfully, they're a newborn, so it's quite a small exam. And we take a full family history. Often we rely on Lauren's pedigrees from the prenatal consultation. If we don't have one, we do our own pedigree. We do get a fair amount of postnatal diagnoses. And then that will guide our conversations as to what type of testing we will recommend. We always obtain parental consent. All genetic testing is optional. And then we like to build on the prenatal discussions that have already happened. As Lauren mentioned earlier, her conversations tend to happen the day that they get the conversation that their child has a defect. So sometimes they don't remember a lot or the bulk of those conversations, but sometimes they have retained a lot of it. So that makes our conversations easy. And then the test determination, as we've mentioned before, we're noticing a lot in isolated CHDs to not stop at the CMA. The CMA is still the gold standard test to recommend, but in particular with laterality defects, we're seeing that single gene mutations are diagnostic. So we have a particular panel for CHD or congenital heart defects that we offer within our hospital. We also offer whole exome sequencing, and we are now pursuing whole genome that Emily and I will offer to some of our more complex heart defects like HLHS, or really complex left-sided lesions like Shone's, or really peculiar ones like a laterality defect mixed with a truncal defect. So when we have two classes of defects mixed together, where we're like, this is unusual. We're a small team, so our testing is not rapid or fast. And so we rely on the patient being pretty stable. If there's at any point an urgency to it, we ask our genetics colleagues to step in and help facilitate that. Mentioning that, so the sample obtainment, critical or not. So if the child is quite critical or imminent demise is apparent, our genetics colleagues have guaranteed that they will facilitate stepping in and taking over the case, because they have the bandwidth to perform rapid testing with a turnaround time of about anywhere from 48 hours to 5 days. Our service does not have that capability. So our turnaround time for testing is about sometimes as early as 1 week, but most of the time about 2 to 4-ish, maybe 6 weeks on the slow time. We prefer to do our results disclosures in person if the patient is still admitted. However, if they're not, we will do it via telephone. We have telehealth capabilities as well that we will do if necessary. And then for continuity, we are very grateful that it's both of us doing this, because it's the same person that met them on admission that's providing them the information weeks down the road. And then we will set them up with any sort of referral or other tests that need to be done, because maybe we found a mutation that says your child may have a renal anomaly later in life, you need to have your kidneys looked at closer, or maybe your child is going to have walking delays. Maybe we need to get you into physical therapy at some point. And so this information is passed along, or the opportunity is seized quicker rather than later. Moving forward with our team, I feel like we are constantly evolving our practice model, mostly because either some gaps within our practice are falling short, or we feel like we could improve on our own. We try to make sure that we're reviewing as best we can which patients need our services and which patients need more escalated services. We're trying to make sure that the children who are getting testing are getting the appropriate testing at all times. We're trying to ensure that every child parent has the ability to be consented to testing before it's sent. We're also constantly working to improve the communication amongst our teams and imparting our knowledge. So we are frequently letting teams know that blood transfusions do not affect individuals' DNA, and that the test will still only test that child's DNA, and that it's okay to obtain a sample after that. And then how we disseminate our information, the best modality of that, we frequently change that up with PowerPoints, flyers, Zoom meetings, Teams meetings, the same way adult education is adult education, and it changes constantly, I think. It's been I think we're going on year 5 now. We've just wrapped up year 4 of our process. Very much enjoy it. We are a strong team, Emily and I. We have a great workflow together. We're well known now, I believe. And so it's been a fun practice model to build. It's been fun to co-lead and introduce. And I know we've been hearing from other institutions across the country about what we are doing and how they can set up. They've been asking for our help. And so at this time, here's a couple of references I have. Happy to pull this slide up later if people have questions now. I just saw the chat was, there's a lot, so we can try to talk through those if we need to.
Thank you. Thank you so much. It's a beautiful talk, and you have a very handsome nephew, I must say.
Thank you.
Now, I mean, Emily is on board. Emily is a genetic counselor, and I think you mentioned Emily quite a lot. And I personally enjoyed listening to you and working as a team, and the team means a lot in performance and in yield. Now, I'd like to ask a few questions, like breaking the news to the family is very important, especially if she's a pregnant lady. Now, Emily, if you would like to come on board with Josephine, what do you tell the parents, like, you know, when we see a hypoplast, there's going to be 3 surgeries and it's going to be other things. And as Lauren said, you don't know about the extra cardiac anomalies that the child. How do you break this news? And do you bring her separately or after and Shane, if you could also share your experience, how do you break the news to such families?
So I think I can speak to this, and I think this is a very stylistic question. I think the way that our team approaches things is, my philosophy is honesty and just kind of laying everything out for families. So kind of from 2 directions from your question, I think, is breaking the news about what having a heart defect and having a child with a heart defect will look like. A lot of that falls on the surgeons, thankfully for us. But when it comes to a positive diagnosis, or how we talk to the families about the possibility of a positive genetic diagnosis, is one, we have upfront conversations about the clinical yield and the clinical utility of testing. And so they're aware of the fact that it's not a 1% chance that we find something upfront. And then when we have children who show even subtle signs or symptoms of genetic conditions, we are just very upfront and saying, hey, we are seeing this, which could be indicative of a genetic disorder.
Emily, I'm talking about antenatal. I'm not talking about postnatal.
Oh, okay,
and
I see.
I'm also talking about somebody that you did not see he's still inside, and hypoplas is not uncommon. But how do you break the news that there is positive genetic test in this hypoplas? So it's not just the hypoplas. You don't know, right? So how do you break the news, and what do you tell them?
So antenatally, I start laying the groundwork for that when I first meet the family for consult. The biggest things that I found in my clinical practice are clear, direct, and simple communication. Also, I kind of use a model now of three main takeaways. So that helps me frame the discussion with the family who may have very limited mental bandwidth for how much they can take in. So I think to myself, if they remember nothing else from my conversation, what are the three main things that I want them to remember? So I will tell them, you know, they, we want to know physically what is going on with the baby, but for their management, we also need to know why it's happening or what might or might not be causing it, and how this is important for the care of their baby. And so I do emphasize that I tell them what percentage is the chance that there is a specific genetic cause versus not just one factor, but maybe multiple genes and environmental factors interacting together. And then we lead into the discussion about what testing is recommended for that. With results disclosures, typically many of our families are not local to the area, so they may be traveling back and forth and are not on the outpatient side, they're not physically accessible to me. So we do a lot of phone disclosures. I will always ask if they are in an environment where they feel comfortable talking, or we can arrange for another time to talk. And I do not bury the lead in the conversation. I will say, I have the test results back. They did show us a genetic explanation for your baby's heart defect. And I'll usually pause to give them time to absorb that news. And then we'll go into the discussion of what does this mean? And usually I'll frame that with what does it mean immediately for the baby in terms of prenatal management, then early neonatal, and then we'll focus on the broader impacts if the family's capable of doing it at that time. We always are happy to schedule more formal follow-up visits.
Thank you. Emily, I got to know that you are talking about postnatal counseling. I'm sorry I stopped you, but it was just the theme was the prenatal. Shane, I just wanted to ask you and Lauren and Josephine and Emily, like if you have a family where one baby is already has congenital heart disease, okay? Like I had a family where she had 7 pregnancies and they all died. I mean, either antenatally, IUFD, or postnatally. And I've seen her when she's gravid at 7, and we diagnosed the fetus in utero with amnio to have something called Dorsey syndrome. Have you heard of that before? Dorsey syndrome. It's a granulocyte. Dorsey is a I think is a Turkish professor of genetics, and he described postnatal defects with the white cell count, so granulocytopenia and so on. And now, it's a long story, but the thing is that she knew that the baby will not survive. It was IUGR, and the baby delivered and died at day 3. Now, they want to get number 8 or 9 and 10. They want a baby. How do you counsel this? I mean, we've done the whole exome for both parents, and they are also heterozygous for another defect. And we're not going to go into that. But the question, how do you counsel, especially in the Middle East where consanguinity rate is high? And the thing is that you don't want to break the family. What happens is sometimes a divorce comes high on the list. How do you deal with such situations as a team?
Yeah, I mean, I can comment on mine, and then of course, this is Lauren's purview as well. When we find cases like that, I think, like Lauren said, just to be really honest, and there are options now, of course, they're expensive, like IVF, but if you know the genetic variant, you can only implant embryos that the baby would not be predicted to be affected. And we do find that in recurrent pregnancies, if they really, really want more children, families often can figure out a way to get this done. Or they accept the knowing that there's a high loss rate. They sort of accept and keep having babies, but they sort of have that knowledge, or they know, this used to not be an option, but there is the option of IVF. And so, we're just honest. They know the frequencies. It's obviously very, very traumatic for these families. But there are options.
Yep. And I will add some nuance to that, is that we have a separate preconception clinic, and we have some genetic counselors there who have lots of expertise with IVF and pre-implantation testing. But there is, specifically when you're talking about a population with a high rate of consanguinity, a consanguineous couple is going to have more trouble with designing the embryo test for IVF, because they need to find other informative markers that always travel with the mutation for the test to be the most accurate. If you have a consanguineous family, they're going to share many, many markers in common. So it's harder to find ones that are informative and useful rather than just coincidental. So that can be one thing that complicates. The other is if they have another disorder that a fetus is at risk for, the more tests that you do on an embryo, the fewer embryos you're going to have that have totally normal test results. And you may need multiple cycles of stimulation and retrieval and testing to get enough embryos to have a viable ongoing pregnancy. Because even with normal test results, not all IVF transfers will be successful. For families where that is not available in their locality, they cannot financially afford it. It also, don't discount the value of early fetal testing. When I talked about those procedures, one of them is available in the first trimester from between 10 to 14 weeks of pregnancy, the chorionic villi sampling. And so if we know the mutations in the family, we can get that placental biopsy and we can test directly for those family mutations. And at least in the US, typically we'll have results back within 3 weeks. So especially for example, like my Muslim families that I work with, the 16 weeks, the 4 months of pregnancy is very often their limit for religious reasons. And so we can usually get them those results to make a decision about termination before that guideline.
Thank you so much. So the message here is that if you have recurrent genetic problem in the family, do PGD, and not just a PGD. You just have to, as you just said, try as much as possible to get a successful fetus, which is not always the case, but they always transfer. I don't know how many when they transfer in IVFs. I think
Typically,
3.
we transfer one embryo at a time.
Oh,
Yeah.
okay. Okay, Shane, you want to go? Okay, I just wanted to ask you one question before you go and before we end. I just want to thank everyone. But if you have, what is the message, Shane, for people and as a fantastic team for counseling, diagnosing and counseling? It's a long story when you get a patient, a fetus with congenital heart disease. What is your advice? What do you tell them? How would you, such doctors, our audience, would deal with such a mishap or a case from all sides, or diagnosis, support, outcomes, and so on?
I mean, that's a huge question, but I just think big picture, I think we need to take a greater responsibility for understanding that a third of our patients probably have a genetic cause of their heart disease, and being knowledgeable and working really closely with genetic providers, whether, whatever role of genetics they're taking in the hospital. And I think historically we're like, let's refer to genetics, and like they have something, they look funny. And I think that we need to challenge ourselves to go above and beyond that, both with figuring out a diagnosis and learning more about the counseling, because it's a huge proportion of our population.
If the patient we diagnose a congenital heart disease and genetic is positive, Emily would have a role as well, antenatally? I think yes, right?
Emily, I don't know if you want to comment. Basically, the prenatal team prepares them and we come up with a postnatal testing plan, and the vast majority of our patients do not get prenatally tested. So they're sort of ready set where Emily and Josie see them when they're, 0 or like a day old, or the genetics team if there's a strong genetic condition suspected.
Okay. I'd like to thank you all for coming, and I'd like to thank Shane. I mean, I had some messages saying that it was a very heavy meal of genetics today, and so I would like a part 2 if possible. Would you promise with a part 2
Yes,
talk?
happy
Thank
to.
you so much. Thank you. And have a good day. And thank you. Thank you for our speakers. And this is a recorded webinar, so you can always find it at the Fetal Series on the YouTube. And I'm really so honored to have such a fantastic all ladies team. And thank you again. I'd like to thank our panelists for sharing their knowledge, and see you soon. Bye-bye. Thank you.
Bye.